Good morning, everyone. Today I'll be presenting a rare case of bilateral optic neuritis in an unusual etiology. Optic neuritis is an inflammatory demyelinating disorder of optic nerve. It has got multiple etiologies. However, multiple sclerosis is the most common. My patient is a 37-year-old female who presented to us with sudden onset diminution of vision in the right eye, which progressed over next 2 days. She also had mild pain in both eyes preceding the onset of diminution of vision. There was no any other ocular complaints. Her positive past history was frequent use of lubricating eye drop. She was a non-diabetic since last 6 years. There was no history of recent febrile illnesses, chronic use or cessation of any drug, recent weight loss or weight gain, any other long-term illnesses. Her general and systemic examination, including CNS examination, was within normal limits. A positive finding in her extraocular movement was she had mild pain in adduction and elevation of the right eye. She had dyschromatopsia in both eyes. Her contrast sensitivity was decreased and RAPD was present in the right eye. Her fundus examination revealed bilateral disc edema, which was asymmetrical more in the right eye. Her visual field showed superior latitudinal defect in the right eye, and left eye had few scattered defects. At this point, we have a young female patient with sudden onset diminution of vision with painful ocular movement and bilateral disc edema. At this stage, our provisional diagnosis was bilateral optic neuritis, query MS or neuromyelitis optica spectrum disorders. We promptly started our patient on pulse IV methylprednisolone 1 gram for 5 days while we were waiting for blood investigation results. Though her blood investigation result did not show us any raised inflammatory markers, her VEP was prolonged in the right eye. Her CSF analysis for MS was also within normal limits. NMO spectral disorders antibodies in the form of aquaporin 4, anti-NMO, P-ANCA and C-ANCA were also negative. We did her MRI brain and orbit, which revealed mild atrophic changes in the supratentorial brain parenchyma, which was not consistent with her age. There was sign of hyperintensity in T2 image in the retrobulbar or intraorbital part in the right eye, and similar enhancement in the left eye, suggestive of optic neuritis. There was a finding of partially empty cella, which is associated with idiopathic intracranial hypertension. However, due to painful optic neuritis without risk factor of IIH, it prompted us to further investigate this patient. We ordered anti-nuclear antibody qualitative analysis, which reveals SSA positivity. This further led us to reconsider her history of frequent use of lubricants and possibility of Sjogren's syndrome as an etiology of optic neuritis. We did her dry eye workup, which came out to be severe dry eye disease in both eyes. Since we had already started her on IV methylpred, we shifted her to oral steroid in topical doses. We also started her on tablet azathioprine 50 mg OD for 1 week, followed by BD doses after a week. Her lubricants in the form of 1% CMC was continued. In follow-up period, at the 6th day after the presentation, she had improved in her visual acuity to 618 in the right eye and 6 in the left. Sjogren's syndrome is a chronic autoimmune exocrineopathy. Hallmark is granular involvement of lacrimal as well as salivary gland. It has got typical manifestations of xerostomia and keratoconjunctivitis sicca. However, in our case, the literature suggests there are few cases of optic neuritis which can precede these typical symptoms and which makes it a diagnostic challenge. Prognosis depend on whether it is associated with any other neuromyelitic spectral disorder. Then the relapse become more, the attacks become severe, it is more morbid, and long-term immunosuppression are needed for those cases. However, still, if it is singly associated with Sjogren's syndrome, it is still prone to recurrence. However, the usual catastrophe is less visually impaired. To conclude, optic neuritis can be rare, but a serious clinical presentation in patients of Sjogren's syndrome without its cardinal symptoms. Hence, it is important to have a high threshold of suspicion, especially in patients of bilateral optic neuritis. These are my references. Thank you.
So what gave you the clue that you have to check for the anti-nuclear antibodies in your patient?
Yes, ma'am. Since the MRI report had typical signs of optic neuritis, there was inflammation, there was hyper intense lesion in the T2 image in the right eye. this led us to think, and since there was no as such associated history of IIH also, so this led us to think there must be something else. And since all the rest of the antibody profile like epaforin,
So
anti-MOG
first you had done the regular
negative.
battery of investigations.
Yes,
Once
yes,
it turned out negative.
yes.
So what other manifestations of Sjogren did your patient have? Other extraocular manifestations?
There was no any other extra other than dry eyes, which we came to know secondarily. First was the optic neuritis itself. So there was no other xerophthalmia or nothing else was there.
Any parotid swelling, submandibular?
Nothing was there.
And how long did you follow up your patient?
Yeah, this is a thing we could not follow it because we lost to follow up this patient. We still hope she comes back to us and we can still investigate her further.
Nice.
Thank you.
What structures are similar between the structures affected in Sjogren syndrome and the structure affected in optic neuritis?
Okay, so it is the retrobulbar part of the optic nerve which is affected in the as shown in the MRI. However, it is the glandular involvement in cases of Sjogren syndrome.
Yes.
In case of neurological manifestations, though optic neuritis is a common factor, however, the middle portion or the towards the brain, it is more affected, the part of the optic nerve.
You must understand my question properly. I am asking you a specific reason. What structure, microscopically, what structure is similar between the glandular structure in a lacrimal gland which is affected in Sjogren's and the optic neuritis?
Okay.
There must be some similarity between these two for them to be affected one or the other earlier than the other.
I'm not very sure, sir, but
Okay,
I think
that's all.
it is the optic chiasma which
There
is
for the benefit of others, the juniors, there is a reason why similar structures are affected in certain cases. You understand?
Yeah.
So you need to go back and look at the anatomy of the lacrimal gland and anatomy of the optic nerve to decide, these two are similar.
okay.
Okay?
Sure.
Right, good,
Thank
well
you.
done.
Thank you, sir.